Hi, this is my second PowerPoint covering the Leik Family Nurse Practitioner Certification Intensive Review. I'll be referencing the 4th edition. I did a previous PowerPoint on safety tips and medications and just things to remember, focused on what is to be expected for the ANNP boards exam. This PowerPoint is specific to cardiac and hypertension medications. And again, it's taken from the Leik review. It's not meant to be all-inclusive. I strongly recommend, if anyone's listening to this, to also get their own copy of the Leik study review. I plan on reading it cover to cover, and this is just kind of another method for me to hopefully learn the material, and if it helps somebody else, then that's awesome too. But again, yes, this is from the Leik review, and this will be focused on the cardiac and hypertension medications and what to focus on for studying for boards. This right here is an outline of the medications listed in the Leik review that are used to treat cardiovascular disease. These are the drug classes, and you can read them here, but they're cardiac glycosides, anticoagulants, ACE inhibitors, ARBs, beta blockers, and calcium channel blockers. The material heavily highlights that cardiac glycosides or digoxin and anticoagulants for our cardiovascular disease. And so that's what this will primarily focus on for that part of the drug classes. And then we'll kind of go into the rest more in depth when discussing hypertension. The first drug is digoxin, and that's from the cardiac glycosides. And this one has a lot of safety issues with it, which is probably why it's so focused on. I'm willing to bet safety is a big part of what is to be expected on the boards. So digoxin, it is used a lot less because we now have newer, safer drugs with less side effects. But we still do see it that it has such a narrow therapeutic range. So the safe zone would be 0.5 to 2.0. And when we start to suspect digoxin toxicity, then we'll start with usually GI symptoms, just simple as nausea, vomiting, but these can turn into electrolyte imbalances and then actual cardiac arrhythmias and a long list of problems from there. So if you suspect that a person might be having digoxin toxicity, then of course you're going to order a dig level, but you should also order your electrolytes to see how those are doing, and also creatinine and serial EKGs, because like I said, there's a possibility that these patients can develop arrhythmias. And then the treatment, which is pretty cool, is actually digoxin specific antibodies. So these antibodies are given to the patient and they bind to the free digoxin in the patient's bloodstream. So it's kind of cool. I actually just had a patient the other day that was on digoxin, and she was there for pancreatitis. And that you better believe that that was one of the things that they were following, because those can get out of range, especially when sick. So again, the Leik review is just that. It is a review, and it's not all-encompassing. But I did feel that they spent quite a bit of time on covering anticoagulants, the vitamin K antagonist, or warfarin, also Coumadin. So patients with valvular diseases or prosthetic heart valves, they are on Coumadin. Also, it's treatment for patients with AFib, DVTs, history of CVAs. The INR for those patients is going to be a little bit different than the ones that we're treating for the mechanical mitral valves. So with our AFib, DVT, CVA patients, we're going to want their INR between 2 and 3. However, with the mechanical valves, we want theirs to be a little longer, 2.5 to 3.5 INR. And then also with our patients with the mechanical mitral valves, they should be taking aspirin as well, a daily aspirin, in between 75 and 100 milligrams a day. So Coumadin, a few facts about it. Its onset takes about 24 to 72 hours after initiating therapy. It's actually a pregnancy category X for all pregnant women except for those who have a mechanical heart valve, and it's actually a pregnancy category D. Really, all I take from that is you don't want to have to give pregnant women, or you don't give pregnant women warfarin. It's also contraindicated in patients with large esophageal varices, thrombocytopenia, any recent eye or brain trauma, or within 72 hours of surgery. And that all makes sense, of course, because they're going to be at a greater risk for bleeding, hemorrhaging, and more complications there. On the right-hand side of this slide, I kind of just go over how to monitor our patients' INRs when they are on the warfarin. So if they are having a consistently stable INR, then we can check them every 2 to 4 weeks with a maximum of 12-week intervals in between checking their INRs. If they have a single out-of-range result that's less than or equal to 0.5 below or above, so it has to be within that range, then we'll just continue with the current dose that they're on, and we'll check them again quicker this time within 1 to 2 weeks. If they have a greater out of range, but their INR is still below 5, with no significant risk of bleeding, so we're going to have to do our due diligence and make sure that they're not at an increased risk of bleeding, then we'll just go ahead and have them skip a dose of their Coumadin, or have them reduce their maintenance dose just slightly. And then, of course, we're going to be following that closely to see how they're tolerating. If the patient happens to miss a dose, it's our job to educate them to actually take that dose as soon as possible, the second they realize it, on the same day. However, if it's the next day, we don't want them doubling up on the dose, so they'll just continue on with their regimen as usual. Also, an important education point for our patients is that actually a high diet in vitamin K can reduce the anticoagulant effect. What is high in vitamin K? For example, kale, spinach, collards, broccoli. Then also we should be telling them that they should be avoiding alcohol while taking Coumadin, or at least no more than 1 to 2 servings occasionally. So occasionally being key there, because we want to educate them that alcohol is also a blood thinner. So direct oral anticoagulants are discussed a little bit in the text, not too much, but it's emphasized that these are preferred for their ease of use. So they have fewer drug interactions, they require less close monitoring from the provider standpoint, so they are easier. Also a decreased bleeding risk, so of course that's a plus. For the Digoxin or Pradaxa, and then there's the reversal link listed there, which I'm not even going to attempt. And then below is the Xarelto or Rivaroxaban or Abixaban or Eliquis. Also there's the reversal, which I'm not going to attempt. But clinical indications for these drugs are, of course, prophylaxis for clotting, also AFib, ACS, orthopedic surgeries. There's, again, like I said, there's reversal agents. And then fresh frozen plasma and prothrombin complex concentrate can also be used for rapid reversal. Less risk of bleeding, easier to monitor, easier to dose, less drug interactions. So overall, just an easier drug to prescribe our patients versus like the Coumadin, if it's possible. And then the Leik text just goes on to also touch on some additional drugs that increase the risk of bleeding. Not too much information was given other than just us, names of the drugs really, and like some tidbits of information or like clinical pearls that we might want to know about these drugs. But of course we know our heparins are going to increase our bleeding. There's our normal heparin, or the low molecular weight heparin, which is our Lovenox. And then our antidote for that is the protamine sulfate, and then our antiplatelets, or clopidogrel or Plavix. There's no antidote there, however, it's thought that the FFPs or cryo can be effective. And then salicylate, there's lots of meds that include salicylate, aspirin, magnesium salicylate, or Doan's pills. This one we know, the bismuth subsalicylate, Pepto-Bismol. And then it takes, what it did mention in there, it takes 4 days for platelet function to return to normal after taking aspirin. Also our NSAIDs, those can increase bleeding. We have Toradol. We don't want to exceed 5 days of use of that drug. And then naproxen, ibuprofen, indomethacin, all of those, of course, increase our risk of bleeding. Also down here, some supplements and vitamins, the ginkgo, garlic, ginseng, fish oil, feverfew, all of these can increase our risk of bleeding too. And so we want to educate our patients if they're taking these to stop taking them at least 7 days before surgery, so we're not worried about increasing the risk of bleeding and complications from that. So as providers, one of our big roles, of course, is preventing disease progression. In this topic, it's cardiovascular disease. So there's a few things that we can do to help improve prognosis. Antiplatelet therapy, of course. So all patients to be treated with aspirin, a daily dose of aspirin. Lipid-lowering therapy, so high-intensity statin regardless of the baseline LDLs. And then ACEs and ARBs, those are going to be renal protective, so those are effective for our patients who have a long list of comorbidities, hypertension, diabetes, chronic kidney disease, or decreased left ventricular ejection fraction, or less than 40%. So those patients are going to be good ACEs and ARBs candidates. And then also treatment of hypertension, smoking cessation, weight loss, quality diabetes control, managing our patient's sugars. All of those things are going to help prevent the progression of cardiovascular disease and are important for our role as providers. So I thought this was pretty cool. I actually took this diagram directly from UpToDate, so you can reference it there, but it is an algorithm for cardiovascular disease risk assessment in adults aged 20 to 79 years old without a history of atherosclerotic cardiovascular disease. So when we're seeing these patients, we can kind of assess them and follow this algorithm and see the treatment that's recommended from UpToDate. So next up is drugs for treating hypertension. And this first slide here is just to kind of go over again how we're going to diagnose hypertension before, of course, we're treating it. So to diagnose, we need an average of 2 or more pressure readings that are hypertensive. If it's 130 to 139, a systolic, or a diastolic of between 80 and 89, we're going to stage as a stage 1 hypertension. Stage 2 is going to be a systolic greater than or equal to 140 and a diastolic of greater than or equal to 90. We want to encourage our patients to be self-monitoring at home. Tell them to take it once a day, keep it in a journal, document it, and make sure they're taking their blood pressures when they're not in pain, obviously, in their least stressed out environment, because sometimes they can get that white coat syndrome. The highest number is going to determine your stage, so regardless of if it's systolic or diastolic, the highest number determines how you're going to stage it. And then for those patients that are at a stage 1 or less than that, but still higher than, the typical 120/80, we can, of course, recommend to them to try the DASH diet or Mediterranean diet, educate them about what weight loss, exercise, being mobile, not being sedentary, meditation, decreasing stress. All of these are modifiable factors that they can do at home to reduce their blood pressure. And this can be an alternative for our patients before, trying medications. And they can try this for about 3 to 6 months as long as they don't have any comorbidities. And again, that they're at a stage 1 or less. Okay, so this slide just goes over the list of classes of drugs that we'll kind of briefly discuss from the Leik text, that is. So there's the thiazide diuretics, potassium-sparing diuretics, mineralocorticoid receptor antagonists, loop diuretics, your ACE inhibitors, your ARBs, your calcium channel blockers, your non-dihydropyridines, beta blockers, direct renin inhibitors, alpha blockers, and then your neprilysin inhibitors and angiotensin II receptor blockers. So diuretics are obviously a mainstay of treatment for blood pressure, and we see it a lot in practice with our patients. But before we go into some of the different medications that the Leik review really focusing on, I just wanted to show that I included this picture here. I didn't actually get this from the Leik review, but I just thought it was nice because it shows how many systems high blood pressure and hypertension really affects in our patient population. So head to toe, there are obvious issues that we will see. For example, I'll read them off, but aneurysm can form after long-term damage to the artery walls from high blood pressure. Problems with memory and understanding. They could be an early sign that high blood pressure is affecting your brain. Sleep apnea has been linked to high blood pressure. Chest pain can be a sign of a heart attack or of reduced blood flow to the heart. Kidney damage happens when high blood pressure damages arteries leading to the kidneys and small vessels in the kidneys. Over time, the kidneys lose their ability to filter waste from the body. Artery damage, high blood pressure wears away at healthy artery walls, causing tears, hardening of the arteries. Over time, damaged artery walls collect cholesterol deposits from blood traveling through, and when this buildup gets thick and hard, it reduces the blood flow. Of course, we know that these can cause blood clots. If the arteries are narrower, a blood clot that might normally travel through can get stuck. This causes a blockage and can lead to heart attack or stroke. Osteoporosis, high blood pressure causes the body to eliminate more calcium, which can lead to osteoporosis. Vaginal dryness or lowered sexual desire, erectile dysfunction, heart failure, high blood pressure, and narrowed arteries make the heart work harder. Heart attack or stroke, we know those are big ones. And that's usually, I feel, what people know, but the rest of this could also potentially be a problem, and it's really important that we educate our patients. So, yes, the heart attack or stroke, untreated high blood pressure can lead to these. Also, left ventricular hypertrophy. When that heart has to work harder to pump blood through the body, it can lead to an enlarged left ventricle, causing hypertrophy of the ventricle. Arrhythmias can occur. Blurred or loss of vision. This is a symptom that we can look out for. These can be results from damaged blood vessels behind the patient's eyes. So I just thought that diagram was really good, comprehensive list of all the areas that hypertension really affects in our patients, and it's just such an important education point with our patients. So often I see patients that know that they've been told they've had high blood pressure multiple times in the past, and they just don't manage it, or they don't see the need or the importance of taking care of their high blood pressure. And so it's important that they know that not only, although stroke and heart attack would be enough for me, but not only stroke and heart attack, those aren't the only risks that come with hypertension, but also all of these other things that can also occur as side effects and really reduce our patient's quality of life. So moving on, we start with our thiazides, hydrochlorothiazide, chlorothalidone, and then indimapide, which I haven't seen actually in practice, and then they're used, of course, for high blood pressure, heart failure, edema, diabetes insipidus, osteoporosis, or osteopenia, along with high blood pressure. These are also good treatments. The thiazides decrease calcium excretion by the kidneys and stimulate osteoblasts. So that's why this is such a good option for our patients who have osteoporosis or osteopenia. Also mentioned was that the chlorothalidone is longer acting and more effective than the hydrochlorothiazide. Adverse reactions and contraindications, there are some. It's contraindicated with patients that have a sulfa allergy. Medications can increase the risk of lithium toxicity, so avoid these with patients that are taking lithium. And then potassium-sparing diuretics are an alternative for patients with these contraindications. Diuretics can elevate your plasma glucose, elevate your cholesterol and your LDLs and your uric acid. So these are all just things that we're going to monitor with our patients that are taking diuretics and make sure that these aren't getting out of whack. Also, they can cause hypokalemia, which again is why we have the potassium-sparing diuretics for those patients that are not able to take these. So as we mentioned in the diuretic slide previously, potassium-sparing diuretics are another option. Or if hypokalemia is a concern with your patient, this is going to be more of an appropriate choice for them. So again, this is a treatment for hypertension, spironolactone or aldactone. There's a few other medications listed there in the class of the potassium-sparing diuretics that you can read. So these have a black box warning, and one I think is probably the most obvious is that it can cause hyperkalemia. And then, of course, we know that that comes with cardiac risks, causing dysrhythmias. So something that we really want to keep an eye on. There's a higher risk with patients that have a renal impairment, also those with diabetes, and then also if it's combined with ACE inhibitors or ARBs. And then finally, the elderly or severely ill. So all of these patients have a higher risk of developing hyperkalemia after taking potassium sparing diuretics. So what are we going to do? We're going to monitor the potassium at baseline before initiating the medication. We're, of course, going to monitor during the treatment at any dose changes that the patient might have, and then illness, because we know that that can throw your body out of whack, and we may see electrolyte changes with those patients. For the spironolactone, we're going to avoid concurrent use with ACE inhibitors, ARBs, salt substitutes, or chronic NSAID use. And then with the spironolactone specifically, there is a black box warning for those, and that it can increase the risk of tumors. And it's just tumors in general. There's just been an increased incidence with those patients, so something to keep in mind. And then also a side effect that can occur with these and that we want to look out for in our male patients is going to be the gynecomastia, or the enlarging of the breast tissue in the male patient. And then loop diuretics is another type of our diuretics that we see a lot in our patients, especially our CHF patients. But also it does, of course, treat hypertension, cirrhosis, renal disease. A lot of patients are on these drugs. We know the furosemide or Lasix, and then the Bumex or bumetanide. Those are the ones we see quite often, and they come with some warnings, but they are good drugs. They're more potent than the thiazides, with shorter duration of action, and they are excreted from the loop of Henle. They're contraindicated in patients with sulfa allergies, and they can cause a lot of everything: hypokalemia, hyponatremia, hypomagnesemia, hypovolemia. Of course, because we are diuresing these patients, we're getting rid of all this extra fluid. But while we're getting rid of this extra fluid, electrolytes tend to go with it. Our patients with a hypovolemia, they'll come in complaining of most likely dizziness, fatigue, pancreatitis. Of course, we'll see jaundice, potentially a rash. Ototoxicity is another side effect of loop diuretics. And I remember learning this in nursing school. We were taught to never push, any medication quickly, obviously, but to be cautious with these diuretics like Lasix, that we don't give our patient ototoxicity. And then the ototoxicity effects can worsen if the patient is also on aminoglycosides. So just something to pay attention to. Just more examples of why it's always so important to look at what other drugs our patients are on and see if the drugs have interactions with one another. And then it does have a loop diuretics also have a black box warning that they can cause profound diuresis, and they require close supervision. So that hopefully is common sense that, again, with diuresing our patients so profoundly, they run the risk of becoming depleted in a lot of necessary things like potassium, which we know can cause a lot of unwanted side effects in our patients. And then I included the picture. Of course, I did not make this. I just was researching and I came across this one, and I like the mnemonic on it. It says treating congestive heart failure, and the mnemonic is unload fast. Upright position, nitrates, Lasix, oxygen, ACE inhibitors, Digoxin. So these are all things that we can use to treat our patients in CHF or things that will improve their symptoms. And then we want to decrease their fluids, afterload, sodium restriction, and test are for the letters for the FAST, but it's fluids decrease, afterload decrease, because we want to decrease those things, sodium restriction, and test for digoxin level and potassium with our patients that are on either digoxin or any other drug that might be affecting their potassium, for example, the diuretics. Next up in our blood pressure medications are our ACEs and ARBs, or angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. A lot easier to say ACEs and ARBs though. These medications, again, treat hypertension or high blood pressure, but these ones are specifically useful because they are renal protective and therefore great option for our diabetic patients. Also, obviously patients that have chronic kidney disease, these are going to be a good medication for them as well. Also, we use this medication in our patients post-MI and in heart failure. However, chronic kidney disease is severe. For example, the GFR is less than 60. We want to avoid due to the risk of hyperkalemia. So we'll have to have another alternative for those patients. We also don't want to mix ACE inhibitors and ARBs together. Also, these drugs are contraindicated in pregnancy. So these will not be the medications we'll be using to manage our hypertensive pregnant ladies. So ACE inhibitors, those are the drugs that end in pril. For example, lisinopril or Zestril, but there are other choices there. So the ACE inhibition stops the conversion of angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. So obviously stopping the conversion of this will stop the vessels from constricting and therefore lower the blood pressure. It's a first-line treatment for our heart failure patients with left ventricular dysfunction. And then education-wise, we want to avoid mixing these drugs with any potassium supplements or potassium-sparing diuretics for obvious reasons, because we don't want our patients to be hyperkalemic. Again, avoid in pregnancy. Also, it does pass the breast milk, so breastfeeding mothers should avoid taking these medications as well. Also, aortic stenosis, angioedema, and symptomatic hypotension. We want to avoid giving these medications to these patients. Also, if there's a new cough that develops that's not associated with an infection, that is, we can switch to an ARB or another blood pressure medication. Again, that's with the ACE inhibitors. A lot of times we'll see our patients that are started on, for example, lisinopril, and they develop a cough. And this can be quite troublesome. Also, cough and angioedema are actually caused by the inhibition of the metabolism of bradykinin, whatever. But this is heavily involved in the inflammatory process, and so these are just alarms for us that these patients need to be switched to a different medication. ARBs, for example, losartan or Cozar is a pretty common one, but there are some others listed there as well. They have less risk of a cough, and so they might be tolerated a little bit better. And then also, instead of stopping the conversion from angiotensin 1 to angiotensin 2, ARBs actually work by just blocking angiotensin 2. So there's a little different mechanism of action there. After that is our calcium channel blockers, and the Leik text very briefly goes over some of those. They're used to treat, again, high blood pressure, of course, which is what we're discussing right now, but also other things such as angina pectoris, coronary artery spasm, supraventricular dysrhythmias, hypertrophic cardiomyopathy, and then Raynaud's phenomenon. It's actually first line for this, and that's because it widens your blood vessels and therefore increases blood flow, and then will help with perfusion and makes sense. So there are two classes that the calcium channel blockers are split up into. There's the dihydropyridines and then the non-dihydropyridines. So the dihydropyridines are your amlodipines, your nifedipines, nicardipines, those drugs. And then the non-dihydropyridines are your kind of different sounding, your verapamil and your diltiazem or your cardizem. So the non-dihydropyridines, they have a few, so they are contraindicated in patients with the AV second to third degree block, patients with sustained bradycardia, and then heart failure with reduced ejection fraction. And then also, it was mentioned in the text that verapamil is not to be mixed with erythromycin or clarithromycin. These drugs have an interaction with one another, and it is contraindicated. Also, a lot of adverse effects come or are possible with calcium channel blockers, and they all, or majority of them, really relate to the vasodilation that's occurring with these drugs. So some of them kind of make sense, are intuitive because of the widening of the blood vessels, but of course we can get hypotension. Then that's of course from the peripheral vasodilation. We can get bradycardia from the reduced cardiac contractility. We can get heart block, and that's from the negative iotropic effects. Headache, again, from the vasodilation, and then peripheral edema. And this, again, is from the vasodilation. And we know this because it's positional, and it will resolve with elevation of the affected limb. Next up is the beta blockers. These meds are, of course, used to treat hypertension. They're also for our post-MI or myocardial infarction patients, patients with arrhythmias. It's also used for migraine prophylaxis. And then also it is a first line of treatment for angina. Up to date, I quoted here in the comments, only anti-anginal drugs proven to prevent reinfarction and improve survival in parties who have sustained an MI. So that's kind of a big deal. So the class of drugs decreases the heart rate and reduces contractility of the heart. So non-cardioselective beta blockers include the propranolol, carvedilol. Those two block beta 1 and beta 2. The cardioselective beta blockers are atenolol and metoprolol. These are more potent of the classes, and they block only beta 1. There's also timolol, which is the oral or the eye drops for the glaucoma. And then, so a couple of notes that were mentioned in the Leik text was, one, we don't want to use these beta blockers with patients with the vasospastic variant, the Prinzmetal angina. So this is those patients that have chest pain at rest, and it usually occurs between midnight and early morning. They are not candidates for beta blockers. Beta blockers are also contraindicated in chronic lung disease, such as asthma, COPD, emphysema, and chronic bronchitis. Patients with bradycardia and second or third degree heart blocks, because we don't want to continue to slow these patients' heart down even more and possibly cause new arrhythmias or death. So adverse effects of beta blockers can be bronchospasms, bradycardia, again, depression, fatigue, and then it can also blunt the hypoglycemic response. So we really want to be educating our diabetics that are taking these beta blockers to be checking their sugars. Also, it can cause erectile dysfunction and even heart failure. So these meds do come with some possible serious adverse effects. If a patient is getting off of them, however, we want to make sure they do not quit these abruptly, as they can cause severe rebound hypertension, and then we could end up in a hypertensive crisis situation. Next up is alpha blockers. These are potent vasodilators, and actually only 2 of them are used to decrease blood pressure, but they are all used for BPH, or benign prostatic hypertension. So the drugs are listed here, but there's terazosin, doxazosin, tamsulosin, and a few others. Terazosin lowers your blood pressure and treats BPH, as well as dexazosin. This also lowers your blood pressure, but these are the only 2 out of these drugs that are used for blood pressure. The other ones, the remaining ones, are used for the BPH. Specifically, I feel like tamsulosin or Flomax is a pretty common one we see with a lot of our patients. these have adverse effects as well. For example, orthostatic hypotension. And we should educate our patients that the initial dose that when they start may actually cause a vasovagal response. So we want them to be aware of this and prepare for this in case it does happen. Be laying down in bed, comfortable at home. This is not the drug you're going to take for your first time and go for a drive. So also it can cause dizziness as well, which would make sense with the possible orthostatic hypotension. But again, we'll tell our patients to take these at bedtime, and then we'll actually slowly increase the dose as needed. We'll very slowly titrate it because it does have such a high risk of that orthostatic hypotension. And then also priapism is a possible adverse effect, and that is when they have the prolonged erection. So that completes the review of the Leik material covering the drugs that treat heart disease and hypertension. Again, this was all taken from the 4th edition of the Family Nurse Practitioner Certification Intensive Review done by Leik, or Maria T. Codina Leik, Leik, that I was reviewing topics covered in this text here, and it again is not comprehensive, and there's a lot more to the list. This was just reviewing of this text, and it helps me to study as I will be taking my boards in a few months, and if it helps anyone else, then great, but regardless, it helps me, so that's pretty cool.